You've read the title, you've understood the abstract, you've followed the argument in the introduction. Now comes the section that determines everything, the methods. This is where you stop trusting and start verifying. Everything the authors promised in the introduction has to hold up against one question. Did they actually design a study that can answer what they set out to answer? A compelling introduction with a poorly designed methods section is like a courtroom argument with no evidence. It sounds convincing. It proves nothing. Most students skip the methods. It's dense. It's technical. It feels like detail for detail's sake. But experienced readers know the methods is where studies are won or lost. Once you know what to look for, it becomes the most revealing section in the paper. There are 6 things you read for in any methods section: the study sample, the eligibility criteria, the outcome measurements, the blinding, the classification system, and the statistical analysis. We'll go through each one and then apply every single one to a real landmark implant study. The first thing you look for is the study sample, and specifically the sample size. Sample size only means something when you connect it to the study design. The same number can be more than enough in one type of study and completely insufficient in another. For a case report, one patient is the entire point. You are not looking for a number. You are looking for a finding worth reporting. For a case series, you need enough cases to identify a pattern. 5 to 10 is a starting point. Fewer than 5, and you are essentially reading multiple case reports side by side. For a cross-sectional study, you are trying to represent a population. A few dozen patients from one clinic cannot represent a city. A few hundred from multiple sites is more credible. For a case control study, the ratio between cases and controls matters as much as the total number. 1-to-1 is common. Adding 2 or 3 controls per case can increase statistical power, especially when cases are rare and hard to find. But very unequal ratios need justification. If a study has 20 cases and 200 controls, ask why. For a cohort study, the number depends on how common the outcome is. If you're tracking implant survival and failure rates are around 2%, you need hundreds of implants to see enough failures to analyze meaningfully. A cohort of 50 implants with 0 failures doesn't tell you the failure rate is 0. It may simply mean the sample was too small to find failures reliably. For an RCT, each group needs to be large enough to detect the difference the researchers defined as clinically meaningful, calculated before the study starts. Fewer than 20 patients per group is a warning sign, not a verdict. If a paper reports no significant difference between groups but never mentions a power calculation, the study may simply have been too small to detect a real difference that exists. For a systematic review, don't just count the patients, count the studies. Then ask whether those studies were well designed, similar enough to combine, and at low risk of bias. A meta-analysis pooling 3 small, flawed studies is weaker than one pooling 15 well-designed RCTs with low heterogeneity and low risk of bias. These are not fixed rules. They are warning signs. The real question is always the same. Is the sample large enough to answer the question reliably, given the design, the outcome, and the effect the study is trying to detect? The second thing you look for in any methods section is the eligibility criteria: who was allowed in and who was kept out. Every study defines 2 sets of criteria: inclusion criteria, the characteristics a participant must have to be eligible, and exclusion criteria, the characteristics that disqualify them. These criteria are not just administrative details. They define the boundaries of the conclusion. The results of a study only apply to people who look like the participants. And the narrower the criteria, the narrower the conclusion. Inclusion criteria tell you who the study was designed for: age range, diagnosis, clinical status, type of treatment received, systemic health. A study that only includes non-smokers with no systemic disease, sufficient bone volume, and good oral hygiene is a study of ideal patients. Its results may be excellent, but they may not apply to a patient who smokes, has uncontrolled diabetes, and needs a bone graft before implant placement. Exclusion criteria tell you who was deliberately kept out, often for good scientific reasons, to reduce confounding variables and make the results cleaner and easier to interpret. But every exclusion narrows the population the conclusion applies to, and sometimes the exclusions are so strict that the study population no longer resembles any real-world patient you will ever treat. This is called the generalizability problem, or in research terminology, external validity. A study can be internally valid, well-designed, carefully executed, honestly reported, and still have limited external validity, meaning its results don't transfer well to your clinical reality. When you read the eligibility criteria, ask 2 questions. First, who is missing from this study? Smokers, diabetics, patients with a history of periodontitis, patients who needed bone grafting. If those patients were excluded, the results may not apply to them. Second, do my patients look like these patients? The more similar your patient population is to the study population, the more directly you can apply the findings. The more different, the more cautious you should be. One more thing to look for: where and by whom the study was conducted. A single university center with highly experienced surgeons operating under controlled academic conditions is not the same as a general dental practice. Results achieved in that environment may not translate directly to community practice. This doesn't make the study less valid. It makes the context of the results important to understand. The eligibility criteria are the frame around the picture. They tell you exactly who the study is and is not talking about. After checking the sample and eligibility criteria, look at the outcomes. Ask 3 questions. What did they measure? How did they measure it? And who measured it? Not all outcomes are equal. Some outcomes are objective, like bone level on a radiograph or implant mobility. They exist independently of who is measuring them and can be standardized and replicated. Some outcomes are subjective, like pain scores, satisfaction ratings, or aesthetic assessments. These are valid and important, but they introduce variability that objective measures do not. And some outcomes are surrogate. They are not the final result we care about, but a marker that may predict it. Marginal bone loss, for example, is used as a marker for long-term implant success. But the question is always, how strong is that link? A surrogate is only as good as the evidence connecting it to the real outcome. When you read what was measured, ask yourself, is this the outcome I actually care about clinically, or is it a proxy? And if it's a proxy, how confident are we that it reflects the real thing? Then ask, how was it measured? Was the method clearly described? Was it standardized? Was calibration done? A vague sentence like bone levels were assessed radiographically is not enough. You need to know the technique, the reference point, and how the measurement was defined and repeated. A measurement protocol that is clearly defined and cited means someone else could replicate it. A vague description introduces uncertainty that cannot be resolved after the fact. Finally, who measured it? Was the assessor blinded? Meaning, did they know which group the patient was in or which treatment they received? We will come back to blinding in the next section. But beyond blinding, consider whether there was one examiner or several. If there were multiple examiners, did they test agreement? If they measured the same thing differently, the data has a problem, regardless of how scientific it looks. Because in research, bad measurements can make weak evidence look strong. The outcome section tells you what the study saw and how clearly it saw it. The 4th thing you look for is blinding. Blinding means keeping someone unaware of which treatment was received, or which group a patient belongs to. And it is one of the most powerful tools in research design for reducing human bias in the results. Why does it matter? Because humans, patients and clinicians alike, behave differently when they know what they're receiving. A patient who knows they received the experimental treatment may report feeling better, even if the treatment had no effect. A clinician who knows which group a patient is in may unconsciously measure or record outcomes differently. These are not dishonest behaviors. They are deeply human ones, and blinding is the mechanism that helps remove them from the equation. There are 3 levels of blinding. Single blind. The patient does not know which treatment they received. The clinician does. This reduces patient bias, but not clinician bias. Double blind. The patient and the person assessing the outcome do not know the group assignment. When feasible, this is one of the strongest designs in RCTs because it reduces bias from both sides, the person receiving the treatment and the person measuring the result. Triple blind. The patient, the outcome assessor, and the statistician analyzing the data are all unaware of group assignments until the analysis is complete. This is the highest level and the most difficult to achieve in clinical dental research. In dental research, full double blinding is often difficult or impossible. You cannot blind a surgeon to whether they performed a bone graft or not. You cannot always blind a patient to whether they received a surgical procedure or a tablet. But where blinding is possible, in outcome assessment, in data analysis, in radiographic measurement, it should be applied, and when it is not applied, the study should acknowledge it as a limitation. When you read the methods, ask who was blinded and who was not. If an RCT reports no blinding at all, the results should be interpreted with caution. If a study reports that the outcome assessor was blinded, that is a meaningful quality marker, even if the treating clinician was not. One important concept related to this is allocation concealment. This is not the same as blinding. Blinding happens after the patient is assigned to a group. Allocation concealment happens before assignment. It means the person enrolling patients does not know which group the next patient will enter. Why does this matter? Because if the clinician knows the next patient will receive the experimental treatment, they may unconsciously choose a patient who is more likely to do well. Allocation concealment prevents this kind of selection bias before it begins. A well-reported RCT should describe both how patients were randomized and whether allocation was concealed from the person enrolling them. In observational studies and retrospective cohorts, blinding is rarely applicable in the traditional sense. You cannot blind a patient to their own smoking history. But in these designs, the outcome assessor can still be blinded to the patient's exposure status. And when this is done, it should be reported. A blinding section tells you how much human judgment, with all its conscious and unconscious biases, was allowed to influence the results. The more blinding, the less room for bias. The less blinding, the more carefully you should read the conclusions. The 5th thing you look for is the classification system. Not every study uses one, but in studies that follow clinical outcomes over time, implant studies, periodontal studies, surgical outcomes, classification systems are critical. They define what counts as success, what counts as survival, and what counts as failure. And these are not the same thing. This distinction matters because the number most often quoted in headlines, textbooks, and marketing materials is the survival rate, not the success rate. And survival rates are almost always higher. A failure means the intervention is no longer functioning or is no longer present. The implant was removed, the graft was lost. The treatment did not achieve its basic purpose. A surviving case means the intervention is still present, but it does not fully meet the criteria for success. The implant is still in the mouth, but it may have bone loss, infection, complications, or may have required additional treatment. It is there, but it is not fully successful. A successful case meets all the predefined criteria for a good outcome. It is stable, has no progressive deterioration, and remains within the limits the study defined as success throughout the follow-up period. So when a study reports 98% survival and 94% success, those are two different numbers. The gap between them tells you how many cases are still present but not fully successful. When you read a study reporting outcomes over time, find the classification system in the methods. What exactly counted as success? What counted as survival? And what counted as failure? Because success criteria are not universal. One study may define success as implant stability with less than 1 millimeter of bone loss. Another may allow 1.5 millimeters. A third may include patient satisfaction. The same implant could be classified as successful in one study and only surviving in another, depending on the criteria used. This means you cannot compare survival or success rates across studies unless you first check whether they use the same definitions. A 97% success rate using strict criteria may reflect better outcomes than a 99% success rate using lenient ones. The classification system is the ruler the study uses to measure its own results. Before you trust the measurement, understand the ruler. The sixth and final thing you look for is the statistical analysis. There are two broad categories: descriptive statistics and inferential statistics. Knowing the difference changes how you read every number in a paper. Descriptive statistics describe what happened in the sample: means, medians, standard deviations, ranges, and frequencies. They tell you the story of the data as it occurred, but they do not tell you whether a result is likely to be real or whether it could have happened by chance. Inferential statistics test hypotheses: p-values, confidence intervals, odds ratios, and hazard ratios. They allow researchers to make inferences beyond the study sample. They ask a different question: is the difference we observed likely to reflect a real effect, or could it be due to chance? The type of statistics should match the study design. If a study has one group and no comparison, descriptive statistics are usually the main analysis. If a study compares two or more groups, like an RCT, cohort study, or case control study, inferential statistics should usually be present. If they are missing, that is worth noticing. When you see a p-value, here's the simplest way to understand it. Imagine flipping a coin 10 times and getting 9 heads. That seems unusual for a fair coin. The p-value answers this question: if the coin were actually fair, how likely is it that I would see a result this extreme or more extreme just by chance? If that probability is very low, you start to suspect the coin may not be fair after all. In research, it works the same way. The p-value tells you, if there were truly no real difference between the two groups being compared, how likely is it that we would see a difference this large or larger just by random chance? A p-value below 0.05 is conventionally called statistically significant. It means that, under the assumption of no real difference, a result this extreme would be unlikely to happen by chance alone. So researchers say the result is statistically significant, meaning it is unlikely to be explained by random variation alone under the no difference assumption. A p-value above 0.05 means the result could plausibly have happened by chance, even if there's no real difference. It does not prove there's no effect. It simply means the evidence is not strong enough to rule out chance. Here's the most important thing to remember. The p-value does not tell you how big the difference is. It does not tell you how important the difference is, and it does not prove that the result is clinically meaningful. It only tells you how compatible the data are with the idea that there is no real difference. But statistical significance is not the same as clinical significance. This distinction changes how you read every results section. A large enough sample can make a tiny, clinically meaningless difference become statistically significant. A 0.1 millimeter difference in bone loss between two groups might reach a p-value of 0.03 in a study with 2,000 patients. Statistically significant, yes. Clinically relevant, probably not. So always ask two separate questions. Is the result statistically significant? And is the result large enough to matter clinically? A good paper reports both the p-value and the actual size of the difference, the effect size. If a paper only reports significance without showing the actual numbers, you cannot judge clinical relevance for yourself. Another important concept is the confidence interval. Here's the simplest way to think about it. A study gives you one number, say an average difference between two groups, but that number came from a sample, not the entire population. If you repeated the study with a different group of patients, you would probably get a slightly different number. The confidence interval gives you a plausible range for the true effect, not just a single number. A 95% confidence interval means that if the same study were repeated many times, about 95% of the confidence intervals calculated this way would contain the true effect. If a treatment improves healing by 2 millimeters with a 95% confidence interval from 1.5 to 2.5 millimeters, the estimate is precise. The likely true effect sits somewhere within a narrow window. But if the interval runs from -1 millimeter to +5 millimeters, that is a wide range. The true effect could be no benefit at all, or it could be a large benefit. The study simply did not have enough precision to narrow it down further. Here's a practical rule. The narrower the confidence interval, the more precise the estimate. The wider the interval, the more uncertainty remains, even if the average number looks impressive on its own. And one more thing to watch for. If a confidence interval for a difference between two groups includes 0, for example, -0.3 millimeters to +1.2 millimeters, that means the true difference could be 0. In other words, there may be no real difference between the groups at all, even if the average numbers look different. When you finish reading the statistical analysis, ask one final question. Do the statistics match the study design? Descriptive statistics for a single-arm cohort. Appropriate. Inferential statistics for an RCT. Expected. Inferential comparisons between groups that were not randomized. Proceed with caution, because the result may be influenced by confounding factors that statistics cannot fully remove. That completes the 6 elements of any method section: the study sample, the eligibility criteria, the outcome measurements, the blinding, the classification system, and the statistical analysis. Now you have a complete toolkit. And in the next part of this episode, we apply every one of these 6 elements to a real landmark implant study, line by line, number by number.